The floor is yours.
Okay, thank you very much, Thibault. So first of all, I'd like to thank Baxter for giving me the opportunity to deliver a talk during this symposium. Here's the first slide. So here is my disclosure slide. Then I move to my outline. So I will first discuss with you the importance of parental nutrition for growth and health outcomes, and then move forward and go into the new guidelines that have been published in December 2018, and then leave you with some take-home messages. So first, I'd like to give you some historical perspectives about the importance of PM in preterm infants, and I like to do this search every year. So I combine the keyword premature infants with respiratory distress syndrome or with nutrition, and for many years there have been much more publications on the topic of respiratory distress syndrome, but you can see that this has changed about during the last decade, and that now nutrition is becoming an important field in neonatology. So research is evolving, knowledge is evolving very quickly, so we need to be to keep to be updated regularly. So to give you some insight about the history of nutrition, so I will not start from the beginning, but I will start about in the year 1999, where the concept of extrauterine growth restriction has been highlighted in several papers. Extrauterine growth restriction describes postnatal growth of preterm infants that is less than the expected growth of a fetus at the same postnatal age. There have been many studies on these topics, and since 2006, a new area is becoming important when the first publication has shown an association between extrauterine growth restriction and impaired development. But since then, we have made some progress, and we looked into more detail and the role of specific nutrients on outcomes. And with regard to protein intake, this study is widely cited. It's a study published by Stephens in Pediatrics in 2009. It's an observational study, and he showed that the protein intake during the first week of life is associated with the developmental score assessed at 18 months. And the conclusion of the paper is that in every 1 grams per kilo per day increase in protein was associated with 8-point increase in MDI. So when you look at this data, it suggests that there is a linear relationship between protein intake and development. And if you just look at the data, at the results, and the conclusion of the abstract, you see that, but I dig a little bit more into the original data, and I found that the first week protein intake was on average 1.8 grams per kilo per day, with a very large range from 0.5 to 2.8 grams per kilo per day. So some babies were receiving almost no protein. There is another observational study which has been published a few years later. It's a very interesting study, but unfortunately it's less cited, and it's really unfortunate because it's a study that we have published, but it shows a different result. It shows that there is an association between lipids during the first 2 weeks of life and neurological development at 1 year, but it shows no association between protein intake and development at 1 year. And when you look at the amount of protein which has been given, it was much higher, since on average it was 3.5 grams per kilo per day, with a range from 1.4 to 4.4 grams per kilo per day. So this raised the question of the relationship between protein intake and outcomes. So there is likely a linear relationship between protein intake and growth, or protein intake and nitrogen retention, as highlighted here on this graph. But the question is there also a linear relationship between protein intake and functional measures like cognitive development? So it's likely that the relationship between the nutrient intake and functions is not linear, and maybe there is a plateau at intakes above the need. So in this case, only individuals with intakes below the need can benefit from an intervention. So if you look at the recent Cochrane review, conclusion is that there is not enough evidence to show an effect on neurodevelopment of high protein intake versus low protein intake in PM. This is based on the analysis of 4 randomized controlled trials. But if I plot this data on my graph, so I've plot first the observational study of Stefan, the observational study of my unit, and if I plot now the amount of protein which was given in the randomized controlled trials, there are between 1.5, 2 grams up to 3 to 4 grams per kilo per day. So maybe there is a threshold here which is important, and below which you may have an effect of protein intake, and below which you do not have any effect anymore. So I think that the relationship between the protein intake and functional measure may not be linear. So then our goal is to provide enough amino acid to prevent neurodevelopment impairment, and not to provide amino acid to increase neurodevelopment. Second issue I'd like to discuss with you is the biological impacts of the 2005 guidelines, and there are been some adverse effects of these guidelines, and that is very important to highlight. First is with regard to chloride intake. In the previous guidelines, 2005 guidelines, it was stated that chloride supplementation follows sodium and potassium, and that's it. In fact, if you look at the real data, that's a study of our unit, we looked at the chloride and sodium intake during the first 10 days in the very preterm infants, and we have shown that the chloride intake is in fact above the sodium intake, and this is due during the first 3 days of life of inadvertent chloride intake because of fluid expansion, likely. But after the day 3 of life, it's due to parenteral nutrition. So this may be responsible of hyperchloremic acidosis. Second biological impact of the 2005 guidelines is with regard to amount of phosphorus which is given. And in fact, it was stated in the previous guidelines that the growing newborn infant should usually receive 1.3 to 3 millimoles per kilo per day of calcium and 1 to 2.3 millimoles of phosphorus per kilo per day, with a calcium to phosphorus ratio in the range of 1.3 to 1.7. In fact, you have to remember that phosphorus is also, of course, used for bone mineralization, but also phosphorus is a principal intracellular anion, mainly in the form of phosphate, and when you promote anabolism, you will use more phosphorus. And this is nicely shown by a French group from Silvia Jacobelli and her husband Francisco Bocente. They have demonstrated that providing more amino acid increase, which is represented here in red, increase the risk of hypophosphatemia. And they have provided an equation in order to calculate the amount of phosphorus. You should provide this equation, take into account the calcium intake, but also the protein accretion. And it's likely that the prevalence of hypophosphatemia in France is high, in France and in Europe. And we, in fact, did a survey in Germany, Italy, France, and United Kingdom, and we were able to show that about 40 to 50% of the prescription of parenteral phosphorus are below the needs. So, saying that, now I'd like to move to the new guidelines. So I will skip the method used for writing the new guidelines for saving some time, and I will directly go into the main differences between the 2005 and 2018 guidelines, highlighting the differences for the three nutrients I've just talked about. For amino acid, was stated that we should provide the first day of life at least 1.5 grams per kilo per day. But the new guidelines is 1.5 to 2.5 grams per kilo per day, so I will discuss this later on during my talk. But for the target, there was a maximum value for the previous guidelines, but now there is a range between 2.5 to 3.5, and by providing this range, at least for the short term, you will prevent malnutrition and promote adequate growth and neurological development. For chloride, there was almost nothing said in 2005. Now it's really highlighted that we have to be careful about chloride intake, and it should be slightly lower than the sum of sodium and potassium intake to avoid metabolic acidosis. For phosphorus, there was nothing stated for the first day of life, and the ratio, calcium-phosphorus ratio, was high. Now it is stated that we have to provide as soon as possible 1 to 2 millimoles per kilo per day of phosphorus, and the target ratio, calcium to phosphorus ratio, should be around 1 or below 1. And we have to be careful about the phosphorus deficiency in infants with intrauterine growth restriction, as we should monitor phosphate concentration. There are some other interesting aspects and recommendations in the new guidelines. So I was in charge of the lipid chapters, and in this we try to answer two questions. So when can we stop lipid emulsion in the very preterm infants? And the second usual question is, what kind of lipid emulsion can we use? So we concluded that lipid emulsion can be started immediately after birth, and there are several studies which have shown that it's possible and safe. And with regard to the type of lipid emulsions, we are a little bit cautious about the use of pure soybean lipid emulsion because it provides a less balanced nutrition than a composite intralipid emulsion. But among all the composite intralipid emulsion, we were not able to recommend one over the other. So for long-term PN, it's better to use any of the composite intralipid emulsion. But what is also I think very interesting in these new recommendations is that there are some recommendations with regard to the status of the children and with regard to the stress. And I'd just like to remind you that there are three phases of the stress response in critically ill children. The acute phase, which is the first phase after the event, which could be injury, infection, surgery, etc., which is characterized by a requirement of vital organ support. Then it's followed by the stable phase. Looks, the baby is getting better, so there is stabilization or weaning of vital support. And then the recovery phase, with clinical stabilization and normalization of all the metabolic alterations. But if we look into details about these three phases, and I use this nice graph published by Justin 2 years ago, it describes very well what is happening in these three phases. So in the acute phase, the inflammation is very high. There is an increase in endogenous glucose production and protein turnover, an increase in counter-regulatory hormones, and the beginning of a decrease in the muscle protein synthesis, as well as a decrease in the IGF-1 and thyroid hormones. In the stable phase, so usually we are quite happy when we are taking care of these babies because they are getting better, but in fact inflammation is really decreasing, but it's still there. There are still some metabolic impairment, and particularly the muscle protein synthesis is still very low. It's even lower than during the acute phase. And that's only during the recovery phase where you have a total normalization of the inflammation status, and you may have an increase in muscle protein synthesis. So the metabolic response is depending on the magnitude, nature, and duration of the injury. It's characterized by a hypermetabolic phase, which is catabolic in nature, characterized by muscle protein breakdown and lipolysis. there is a loss of control of energy substrate utilization by their availability. And also what is very important is that providing glucose and energy intake will not impact the protein metabolism. So hypercatabolism and muscle atrophy are not reversed by increased provision of nutrients. This may suggest that providing too much nutrient may be detrimental during the acute phase and maybe during the stabilization phase. And this, we have some good data suggesting that maybe this is the case. It comes from the PPANIC trial, so you have probably heard about this PPANIC trial. It's a randomized controlled trial performed in PQs. The infants, the children were randomized to either parenteral nutrition from admission or withholding parenteral nutrition for a week. And there was a subgroup analysis which was pre-planned and published later in the Lancet. And they have reported the data, and they have shown that withholding parenteral nutrition for 1 week lowers the risk of sepsis, allow earlier life discharge in the expense of higher risk of hypoglycemia. So maybe it may be beneficial not to push too hard on parenteral nutrition. By looking at the type of micronutrient which may be involved, it appears in this study that this is associated with the amount of amino acid. And with increasing doses of amino acid, there was a higher likelihood of occurring a new infection, a lower likelihood of earlier life winning from mechanical ventilation, a lower likelihood of earlier life PQ discharge, and the risk of harm, interestingly enough, was shown even for low doses. And in contrast, glucose and lipids appears to be more beneficial than amino acid. So my conclusion would be that early administration of amino acid, but not glucose and lipids, could explain harm caused by the early supplemental parenteral nutrition in clearly children. And there is also another study I like to quote here, which is a NEON trial. So it's a very nice study. It's a 2x2 factorial double-blind multicenter randomized controlled trial. Testing high, which is 3.3 grams per kilo per day of protein versus low, which was 1.7 grams per kilo per day the first day in the PM. So it's a randomized controlled trial with the aim of changing the body composition at expected term. The results are very interesting because there is no significant difference between the two groups with regard to non-adipose mass, weight, and length. So it fails to show an effect, a beneficial effect on the quality of growth. But the head circumference at term was smaller in the high protein group, and they were also more likely to have BUN concentration high, above 7 millimole per liter or above 10 millimole per liter. So my personal advice would be not to push too hard on amino acid the first day, and not to push too hard on amino acid when the baby is in a stress situation. So I would stay within the recommendation for amino acid between 1.5 to 2.5 and not exceed 2.5, as some units are already doing in routine practice. Also very interesting, we are always afraid of hypoglycemia, but in these guidelines there is a whole paragraph on hyperglycemia, which may be detrimental. It's increased mortality, increased morbidity, sepsis, neck, brain damage, impaired development, and retinopathy of prematurity. And this go well with our with the data that we have in our lab, published by Elsa Kermorvan, showing that in a rat model that hyperglycemia may be really detrimental for the retina, and that we have to be careful about preventing hyperglycemia in these babies. And I'd like to remind you that the capacity of glucose oxidation in a preterm infant is limited. This can be assessed by using a stable isotope. It has been shown that in preterm infants, the glucose oxidation rate is at maximum around 2 grams per kilo per day. So if you provide more than 2 grams per kilo per day, this glucose is going to be directed to lipogenesis and not be oxidized and used as an energy source. For term infants, the glucose oxidation rate is higher, around 17 grams per kilo per day. So in the new guidelines, you have this type of table for energy and glucose. So it's a kind of interesting because you have two entries: the age of the children, but also the status. Is the baby, is the children in the acute phase, stable phase, and recovery phase. So there are different recommendations according to the status of the children in the PICU or in the NICU. Then the last thing I'd like to highlight is the fact that in the previous guideline there was 12 chapters, so now there are 14 chapters, so there are some new topics in the guidelines. And in fact, there is a whole chapter entitled Individualized versus Standard Parental Nutrition. And I think there has been a complete change in paradigm, since in the previous guideline in 2005, it was stated that standard PN do not meet all the requirements of newborns, and that uncritical use of standard formulation, particularly over a long period of time, may be detrimental for growth and development. But in the new guidelines, so a lot of things have changed between these two dates, and now it is recommended to use standard PN solution. This should be generally be used over individualized solution in the majority of pediatric and newborn patients, including the very low birth weight infants. So I'd like to finish with this little tool made by EBSCAN. So it's published on the website ebscan.info. It's a tool which helps you to prescribe parenteral nutrition according to the new guidelines. So you enter the age, weight of the baby, and then you will have some proposal which take into account the new guidelines. You will have a proposal for all the nutrients. So you will find it on ebscan.info. So take-home messages. So I think that knowledge in neonatal nutrition is rapidly increasing. That extrauterine growth restriction is still prevalent, may be reduced by optimizing both parenteral and enteral nutrition. This may in turn improve long-term outcome. Nutritional deficit should be avoided, and parenteral nutrition should be started from birth. Providing amino acid in the range of the 2018 recommendations should improve short-term growth outcome and should support neurodevelopment. Promoting excessive growth or promoting excessive nutrient intake does not improve neurological outcome, so we have to be careful about that. Changes in a single nutrient in PN could be detrimental. So that's the example of amino acid, improving the amount of amino acid in the PN, but not adjusting for phosphorus. So it could be detrimental. So it's important to use standardization, and since it has been shown that standardization of PN will improve outcome, at least at the country level. So the new recommendations have been recently issued, about less than a year ago, and we should put a lot of efforts to implement them in our country and in our units. Thank you very much for your attention.
Thank you, Alexandre, for this very nice presentation. And maybe we can take the time for a few questions, or we can we will wait perhaps for the question at the end of the two presentations. Yes, and we will move now to the presentation of Kenny McCormick. Kenny McCormick is a neonatologist in Oxford in the UK and a clinical lead of Thames Valley Neonatal Network. And he will present us the routine use of a standardized 3-in-1 PN formulation in a quality improvement project in level 3 NICU in the UK. Please, Kenny.
Thank you very much, Thibault, and thank you for the opportunity of sharing our experience in Oxford with actually taking the science and taking the standardised parental nutrition products and putting them into practice. This is slightly different to Alexander's talk because, of course, he's given you the science. So what I'm going to give you is the experience, and this is unashamedly a quality improvement project and not a randomised controlled trial. I think there might be some seats have been vacated over there. I'm not quite sure if the first in should get the seats, but there might be an unseemly fight for them otherwise. I do have some disclosures to make. Is this sound okay? Is the sound okay at the back? You want me to talk up a bit? Okay. Is that better? I should disclose that the nursing time for the project implementation and data collection was supported by an educational grant from Baxter, but they've had no input into the project design or interpretation of results. And I should thank my pharmacist, Mar Moreno, Lindsay McFarlane, who's our practice development nurse, and Alex Griffiths, who's one of our research fellows. Just to give you a little bit of background about my hospital so that you can try and see if the populations are similar to your own hospitals, we have a single designated level 3 NICU, which also provides surgery for a population with a birth rate of around 27,000 babies in the surrounding region. And we have those number of intensive and high dependency cots, around about 200 babies a year, less than 1,500 grams annually, of whom more than 80% are inborn. And for those of you not familiar with the centralisation process that's gone on within the UK, it's expected that all babies under 27 weeks gestation, all multiples under 28 weeks gestation, and all babies with a birth weight expected to be under 800 grams weight would deliver in a tertiary unit. So in other words, antenatal transfer is very much promoted. Alexander didn't show this other presentation or paper of his, which shows the need for PN, and this is his paper from 2013 and a survey of units in the UK, Italy, France and Germany. And what he and his workers found was that PN was often prescribed at inadequate levels, certainly during the first few days of life. And I think that message and those findings, along with other findings at the same time, maybe even better, what he found, along with others, was that because of the inadequacy of early parental nutrition, it really did cry out for standardization to become a much greater part of practice. We have had a standardized approach for the last 8 years or so. Previously, Baxter did provide our PN solutions, and we had a 2-in-1, so aqueous solution plus a separate lipid solution. And you can see that in the past we used SMOF lipid, and you can see that generally we were in line with the SPGAN guidelines of that time with regards to the amount of the macronutrients that we were given in each of these days. We found that we individualized around 15% of our parental nutrition, even using this standardized approach. And then the question is, well, why would you want to change? Because if you've got a standardized approach, and if you're getting fairly adequate growth, and if you're able to adhere to SPGAN, what are the reasons for changing? And this is one of 4 cases that we had seen over the case of 5 years. Not all of them from my own unit, I should point out. But this is a case of a baby who collapsed in a neighbouring unit because of parental nutrition overdose, particularly the lipid component. And these are the initial test tubes or syringes full of the exchange transfusion blood. And you can see very clearly on the far side there appears to be more lipid than blood. And gradually during the exchange transfusion, you can see the amount of lipid, at least visually, going down with each part of the exchange. And we know that this experience is not unique to us. Many other units have seen it. And in fact, in 2017, there was an NHS National Patient Safety Alert pointing out the risk of giving parental nutrition too rapidly in babies. And what they found was that mostly the errors were as a result of the lipid rate and the aqueous solution rate being switched, so that babies were getting the aqueous rate but in lipids. And they described 10 incidents in a 3.5-year period with near on 700 near-miss incidents in the same period. And we know almost certainly that this is an underrepresentation. They also made a number of recommendations about how one should minimize these errors. And we, in fact, had already introduced throughout the region a number of these points in advance of this alert coming out. And even then, we still saw some babies coming in with lipid overdoses. So we asked ourselves the question, would a change from a standardized 2-component system to a standardized all-in-one bag give comparable outcomes while reducing the risk of wrong rate infusion? And we knew that because wrong rate infusion was relatively rare, we would never show a difference within our unit, but we were interested in the other outcomes of giving parenteral nutrition. The other thing about using the standardized 3-in-1 solution, and this was something that I hadn't been particularly aware of before, is that the 3-in-1 solution is actually licensed for use in neonates. Now, when we make a change in our unit, we have to go in front of the medicines committee of the hospital to plead for a change in what we're doing with pharmaceutical agents and with feeding agents and parenteral nutrition agents as well. But in fact, when we explained that this was a licensed product and would be given in line with the recommendations from the Medicines and Healthcare Products Regulatory Authority, they were very happy with that change. So actually what we were doing before, we were using products which had been developed for use in neonates, but because of how they were compounded, they weren't licensed. So our own unit guidelines will be very similar, I'm sure, to your own guidelines for use of parenteral nutrition. There will be, I'm sure, some differences, but in general, we use it in all babies who are less than 32 weeks gestation, or babies with a birth weight of less than 1,500 grams. Those anticipated to be nil by mouth for more than 24 hours. Failure to establish good volumes of breast milk feeding or milk feeding, and any neonate whose milk is stopped for longer than 24 hours. And we have that as a generalized approach. Previously, as I said, we used an aqueous component, and our lipid component was a SMOF lipid. And we changed the aqueous component every 48 hours and the lipid component every 24 hours. And we tended to use a low electrolyte bag as a starter bag, then a maintenance bag, but we also had available to us a low glucose bag should hyperglycemia become an issue. And again, many of you will be familiar with this approach. And we also had the ability to give individualized bags. And as I pointed out earlier on, around 15% or so of our babies used to get individualized bags when we were prescribing PN. The 3-in-1 regimen was a standardized 3-in-1 bag, and you probably will have seen some marketing for Numeta G13, and many of you will be using G13 at the moment. But because we were going to introduce it, we thought we would take the opportunity to actually look at what some of the outcomes were. We know it's got a slightly higher osmolarity. The lipid source is clinoleic rather than SMOF. Of course, once you activate the bag, you have a fixed lipid protein carbohydrate ratio. It is administered as an all-in-one. We add the micronutrients in our pharmacy, not on our unit, but we can use the bags without micronutrients straight from the shelf, so that babies, when they're born, can have a bag of parenteral nutrition started hopefully within 4 hours. And with this 3-in-1 regimen, because of the lipid component, everything gets changed every 24 hours. Again, we had similar regimens for both before and after. So we plan to initiate parenteral nutrition within 4 hours via a central line if possible. We don't allow any additions to the parenteral nutrition bag or burette on the ward. They have to be made in a sterile environment in pharmacy, but we can co-infuse electrolytes alongside the parenteral nutrition. We introduce human milk, and we've got a breast milk bank in Oxford, usually on day 1 if we can, and increase milk at those rates. We fortify routinely at 120 mils per kilo per day, although with the presentations that we're seeing now, I'm sure we'll come earlier and earlier with when we fortify. And we discontinue parenteral nutrition once we reach a milk intake of 150 mils per kilo per day. And we only use individualised parenteral nutrition with senior agreements. And we made no other changes to our nutritional management of preterm babies during this period. This shows you the before and after nutrition composition comparison between the 2-in-1 and then the later 3-in-1 component. And you can let your eye run over the table. You can see that there aren't too many differences. Again, the starter bag that we use is a licensed 3-in-1 solution, which is mixed together at ward level, but our maintenance bag is that bag with micronutrients added. And you can see that we also have a peripheral bag, a low glucose bag, and the ability to use individualized PN if it was felt warranted. We plan to evaluate over a 12-month period, 6 months before and 6 months afterwards, looking at metabolic stability, growth, cost, adverse effects, and numbers of times that we had to change our parenteral nutrition. And because this was a quality improvement project and because it was using a licensed product, we didn't require any additional regulatory approvals. We always planned that this would be descriptive rather than statistical. And after the 1st of October 2018, our plan was that all babies who were eligible for PN would start on the 3-in-1 bag. So what did we find? We had around 280 babies over the course of that year who were put on parenteral nutrition. You remember that we also look after surgical babies. On average, before and after, they had 10 days of parenteral nutrition. And on average, you can see that the number of times that we had to change from the prescribed parenteral nutrition to something else was similar, 5.7% of parenteral nutrition days before, 4.6% afterwards. Our rate of cholestasis didn't change. And although there looks to be a difference in weight score, we did do some exploratory statistics, and there were no changes in the weight Z score between babies who were on the 2-in-1 plus lipids as opposed to those babies on the 3-in-1 solution. If we just concentrate on the preterm babies, less than 32 weeks gestation, you can see that that subgroup had slightly greater days of PN, but they were the same before and after. The number of changes to PN were the same. The number of babies who required insulin, in other words, who weren't managed with a low glucose concentration, were the same. In these preterm babies, the cholestasis was effectively the same as well. And the change in weight score, although it looks significant on testing, it isn't. And when you actually look at how many babies needed anything other than standardized PN, it was a handful, 6 before, 7 afterwards. We also looked at what our nurses got up to in changing parenteral nutrition. And our unit, like most of your units, will have 2 nurses checking parenteral nutrition when the changes come. And you can see that the average time to change over nutrition previously and before was effectively halved. So 15 minutes, 2 nurses each before, 8 minutes, 2 nurses each afterwards, which doesn't sound very much, but in a unit our size and with the number of days of PN we give, that's around about 700 hours every year, or about 19 weeks of a whole-time equivalent nurse. The costs, I was tempted to give these in pounds, but because the pound seems to be crashing day by day, I thought it was probably better just to give it in percentages. But you can see that there were savings in consumables and nursing costs, but actually the PN was roughly the same. But overall, there was about a 15% saving on a 10-day course of parenteral nutrition. And if you look at a more stable currency, the euro, you'll see that there were differences with the cost of parenteral nutrition. There was an overall saving with the 3-in-1 bag, which equated again in the size of our unit to around about 40,000 euros a year. So when you look at all babies and how many bags we used, at least 3/4 of our babies were managed using the 3-in-1 licensed bag, either before micronutrients were added or after micronutrients were added. And if you look at the number of babies who had compounded individualized bags, in fact, it was only 6% or so of babies per day who had that individualised approach. But of course, as you've noticed, something that we do, which perhaps not everyone does, is we say that we want to give central line PN. And the British Association of Perinatal Medicine recently, and in 2015, came up with a framework for practice for use of parenteral nutrition. But in spite of this, we still see some complications. So BAPM pointed out some of the risks that might be attendant on peripherally inserted long lines where you use the left leg. And they described 2 cases of babies where the babies became paralysed because of inadvertent extravasation into the epidural plexus. So even though they had a framework in 2015, even though they updated it in 2018, as more and more people are using central line, certainly within the UK, we recognise that there's an increase in complications. And the reason that I bring that up is we also looked through our reporting system at any adverse events. And of course, these are the data that I'm sure Baxter would rather weren't there. And when I was doing given that I had oversight of the quality improvement project, I was worried because you can see that in the first 6 months with the old regimen, we had 9 extravasation injuries. In the later regimen, we had 21 extravasation injuries. Now, at this stage, I stepped back and I asked my colleagues who oversee governance within our hospital and governance within the trust to look as independently as they possibly could at what they felt was the cause of extravasation in each of these cases. What they found, somewhat to my surprise, was they came up with the conclusion that this had nothing to do with the type of parenteral nutrition, but instead we had inadvertently slipped into practices with long line placement, which almost certainly gave the largest contribution to extravasation injuries. So as a consequence of that, we have now started a quality improvement project around UVC and peripheral catheter insertion. And we also recommended we changed our recommendations about central line placement. We asked that if people were using a short central line, in other words, one that wasn't in the ideal position, that they use a low concentration PN. And we were somewhat reassured, and Alexander referred to the NEON trial, that in the trials that have looked at using more concentrated PN, there doesn't seem to have been an increased extravasation rate. Our other learning was about the placement of upper line, long lines in preterm babies. And what we realised, and many of you will already know this, but we had to relearn it again, is that those lines which are inserted in the lateral aspect of the arm are very likely to get stuck at the clavipectoral fascia. Now, we knew this, but it's clear that our eye came off the ball because we found that many of our cases of extravasation had lines which were slightly short but were in this position. So, again, with the qualification that this is a single centre experience, these are our lessons from this quality improvement project. We feel on balance that the metabolic tolerance was equivalent between both the regimens. We felt that growth was equivalent. All of our babies were started on a standardised parenteral nutrition, and almost all of them can continue to be managed with a standardised parenteral nutrition thereafter. It does seem, certainly within the UK, within a unit our size, that the 3-in-1 system was more cost effective, and we have to take it at face value that it will avoid the risk of infusing lipids at the aqueous rate, because of course these cases are so rare that we would never see it from a single site. Of course, the 3-in-1 product does now comply with the UK MHRA guidance for use of licensed products. But importantly, if you are doing quality improvement projects into parenteral nutrition, then you should look at all aspects of the administration of parenteral nutrition in case things that you hadn't anticipated come up. And I would advise, if you're doing that, then you try and get as independent a review of any adverse effects if they arise. And as I said, in our case, it was felt that the adverse effects were as a consequence of placement rather than